I'm your moderator. I'm Brian Irons. I'm a professor with the Texas Tech School of Pharmacy at the Health Science Center in Lubbock, Texas. I'm also the division head of ambulatory care. I'm board certified in ambulatory care pharmacy and board certified in advanced diabetes management. I'm no longer a BCPS. I was for 14 years and let it lapse after I got my AmCare boards a few years back. Anything else about me? I went to school in Wisconsin, PGY1 in St. Paul, Minnesota, and my PGY2 at Texas Tech, where I've been a faculty member since 1999. So with that, we're going to get right back on track and talk about endocrine and metabolic disorders. Everything you ever wanted to know in 75 minutes. I wish it was everything you want to know. Unfortunately, with 75 minutes, we can only really hit the highlights of the things. I have no conflicts of interest. What we are going to review, however, is the main concepts in the treatment of hypo and hyperthyroidism. We're going to look at Cushing's disease as part of the adrenal insufficiency and adrenal disorders. We're going to look at obesity and a lot of the newer medications out to treat obesity over the last few years and wind things up and spend most of our time on diabetes management, in the particular diabetes mellitus. Things we won't cover that are actually covered in your workbook include pituitary disorder, which we're not actually going to hit, hypoadrenal disorders, which we're not going to talk about, PCOS, and diabetes insipidus. But again, there's a lot of the useful information in your workbook on those different topics. So with that, let's start with thyroid disorders. And first, we're going to start out with hyperthyroidism. We're going to focus our time on Graves' disease, which is probably the more common disorder you're going to see in hyperthyroidism. Again, this is where it's an autoimmune disorder where your body naturally stimulates T3 and T4 synthesis and release by mimicking through antibodies of your naturally formed TSH. So it kind of mimics TSH and spits out way too much T3 and T4 in the body. There's other information on thyroid storm, pituitary adenomas and the like in your workbook, subacute thyroiditis, drug-induced hyperthyroidism. Amiodarone is one of those drugs that is notorious for causing either hypo or hyperthyroidism. And in a lot of cases, if the patient is receiving too much therapy for hypothyroidism, they can become hyperthyroid. It's also another cause of hyperthyroid disorders. And we're not going to cover subclinical hyperthyroidism today either. Well, if you look at the labs, your TSH level and your free T4 can tell most of the story of what the patient has. Not all of it, but most of it. In Graves' disease, you're going to have a low TSH level and elevated free T4 level. Those elevated T3 and T4 levels in the body help turn on that negative feedback mechanism to the pituitary and shut off TSH production. If you have an adenoma in the pituitary gland, however, and this isn't Graves' disease, it's a different cause of it, you can see abnormally high TSH levels as well as elevated T3 and T4 levels. From diagnostic purposes, they can get antibodies for the thyroid and in some cases radioactive iodine uptake, though it's lost a little favor over the years. When I talk to my pharmacy students and residents and medical students and residents, I always tell them that your thyroid is like your thermostat. When it's revved up, everything is going at a increased rate. With respect to the presentation for patients with hyperthyroidism, they often have increased appetite, weight loss, may or may not have a goiter. They're usually heat intolerant, often have fine hair, have cardiovascular aspects, including tachycardia, in some cases palpitations, in worst case scenarios, MI. They can be very nervous, anxious, and often have insomnia, as well as have moist skin, sweating, and that bulging eyes that you remember from your pharmacotherapy sequence when you're a student. Well, the goals for thyroid disorder, in this case, the first three are like any disorder, is to improve the overall quality of life of the patient, to minimize or eliminate symptoms, to minimize the long-term damage, which there is a lot of with hyperthyroidism, and to normalize the free T4 and the TSH levels in the body. So our first case, and I don't cover every single case I have in my workbook, but we're going to hit the highlights. We have a woman who's just recently diagnosed with Graves' disease. She does not want to undergo ablative therapy, which is usually the treatment of choice, but she wants to try medications instead. She has a low TSH, a high free T4, and complains of feeling anxious and warm all the time when everybody else feels cold. So, using our ultra-high-tech audience response system, which is the most appropriate initial option for this patient? Is iodine therapy, PTU, atenolol, or methimazole? All right. See a little smattering, mostly yellow out there. Good. All right. Again, the treatment of choice for hyperthyroidism and Graves' disease is ablative therapy using radioactive iodine. If it's due to a pituitary adenoma or anything like that, anything with an adenoma, I want it out of my body. A lymphoma, adenoma, melanoma, anything like that, I want it out of my body. That's all there is to it. So anything with endometrioma is a bad thing. You want surgical resection for it. So if it's a secondary cause during an adenoma, you want to do surgical removal of that adenoma. But from a Graves' disease standpoint, it's ablative therapy. We usually reserve pharmacotherapy for patients who are either awaiting ablative therapy or surgery because it helps deplete stored hormones in the thyroid gland, or a patient is not a surgical or ablative candidate or refuses such, like in our case, or if you've already done ablative therapy and or surgery and it simply wasn't sufficient enough to normalize thyroid levels. Well, the drugs we usually use haven't changed in a very long time. Same things you learned in pharmacy school. PTU and methimazole inhibit the iodination and the synthesis of T3 and T4 in the thyroid gland. Based on the current recommendations out there, methimazole is the preferred agent based on its ADR profile compared to PTU, which we'll talk about in a moment. It usually requires monthly dose titrations, usually guided by your symptoms and your TSH level and free T4 to a certain extent. By itself, it doesn't work really, really well. And it's not certainly going to put most patients into quote-unquote remission after 1 to 2 years of therapy using PTU or methimazole. It may take several weeks for symptomatic improvement, and we may not see the maximal effect of these agents for up to 4 to 6 months in some cases. Neither drug is actually more efficient than the other. They're both effective in the same way. But based on the ADR profile, PTU has been associated with hepatotoxicity, and hence why methimazole is considered the drug of choice over it. And based on the current recommendations, if you are going to use the PTU, particularly in the case of pregnancy, you want to obtain baseline LFTs. Well, both agents can cause arthralgias, fever, rash, leukopenia, which is usually transient, and worst case scenarios, agranulocytosis. Current recommendations are to obtain a baseline CBC prior to starting either agent. We can still use beta-blockers. They're not great from an efficacy standpoint to normalize T3 or TSH for that matter, but they're great in symptomatic improvement. We think of that anxiety, the tremor, heart palpitations, tachycardia, and the like. And beta-blockers are quite useful from a symptomatic standpoint. For the recommendations, they are recommended in symptomatic patients who are older, those who have heart rates greater than 90, or have a history of cardiovascular disease. And they're suggested as an alternative for patients who are, any patient symptomatic regardless of age. Iodines you can use. They help to block the release of stored hormone in the thyroid gland, but you usually want to use them for only a short amount of time because the thyroid gland will have a tendency to leach more thyroid hormones out of it with continued use more than 1 to 2 weeks. So they're very limited prior to usually surgery. So back to our case then, the obvious answer for this patient who's newly diagnosed with Graves who does not want to undergo ablative therapy would be the use of D-methimazole. Or methimazole, depending on which side of the Mississippi you're from. Switching gears to hypothyroidism. And again, we're going to talk about and focus on Hashimoto's disease, which is an autoimmune-mediated disease where your body is attacking your own thyroid gland. There are other causes for hypothyroidism. Again, ablative therapy, most patients long-term are going to need thyroid replacement therapy after undergoing ablative therapy. And surgery is certainly not without its risk as well. You may not get all the adenoma out of the thyroid gland. Not too big a problem in the U.S., but some countries have a deficiency in iodine that can also lead to hypothyroidism. There will be some secondary causes, in particular an insufficiency of the pituitary gland, where you don't secrete any TSH. It can be drug-induced, just like we talked about before. Amiodarone can cause either hyper or hypo, and lithium is associated with hypothyroidism as well. We can have myxedema coma and subclinical hypothyroidism, but we're going to focus on Hashimoto's. Just like in hyperthyroidism, the TSH level and the free T4 tell a whole lot of the story. It's usually the TSH is going to be high because you lack that negative feedback mechanism. There's not enough T3 or T4 to shut the pituitary down, so the TSH level continues to increase even though it's fairly ineffective. And you see suppressed free T4 levels. If it's a secondary cause, such as a pituitary cause, the TSH may be low or normal. And again, from a diagnostic standpoint, we can do antibodies of the thyroid. Screening recommendations. Even though hypothyroidism, Hashimoto's, is a very common disorder, particularly among women, there are no great consensus recommendations. It seems like every group has a different entity on who to screen and how often to screen, so we're going to kind of bypass that controversy. Exact opposite when it comes to clinical presentation. Instead of increased appetite, they have appetite suppression, often gain weight, have dry skin instead of moist skin, are cold intolerant instead of heat intolerant, feel run down, lethargic, fatigued all the time. Instead of tachycardia, we often have bradycardia, slow reflexes, and coarse skin and hair. So patient 2, we have a 63-year-old woman with a new diagnosis of Hashimoto's disease. TSH is elevated at 10.6. The free T4 is low at 0.5. She has dry skin and complains of being run down. What is the best initial therapy for this patient? Is it levothyroxine, leothreonine, desiccated thyroid, or methimazole? And if anybody answers D, you weren't paying attention to my previous slides. I couldn't come up with a better answer. Well, the drug of choice is synthetic T4 levothyroxine, the brand name Synthroid, and it has generic as well. Based on its overall cost, based on the fact that it has very low allergic entity compared to some of the other thyroid preparations, has a significant potency, and has a pretty good ADR profile overall. You usually titrate about every 4 to 6 weeks based on its half-life, which is usually about a week, and base your titration on both symptoms as well as the free T4 and TSH. You can overshoot, however. Again, one of the main causes of hyperthyroidism is overcompensating with levothyroxine. And worst case scenarios can cause an MI, angina, and it can increase your risk for bone fractures. So you want to keep the TSH and the free T4 normalized as long as possible. So obviously the answer for patient case 2 is A, levothyroxine. And now for something completely different. Adrenal disorders. The meta chapter has a whole bunch of different things on adrenal disorders. Hypo, such as Addison's, and hyper and Cushing syndrome and the like. The treatment goals for adrenal disorders are to overall reduce morbidity and mortality associated with whatever condition they have, eliminate the cause if it isn't known, to help reverse any clinical features of it, and they're pretty extensive, to normalize biochemical changes and put the patient in remission or long-term control without reoccurrence. Again, there are a lot of different adrenal disorders. We're going to focus mainly on Cushing's disease. Now, Cushing's syndrome is kind of an umbrella term for a lot of different conditions, and they can be ACTH dependent or ACTH independent. Cushing's disease is actually more of a pituitary disorder than an adrenal disorder, but it's kind of both, really. But it starts as a pituitary adenoma. And you have excessive ACTH secretion into the adrenal gland and hence an extreme amount of cortisol levels in the body. But it can be ACTH independent, in particular if you take too much corticosteroids, methacorticosteroids, and the like, that you can actually have a Cushing syndrome as well. From a hyposecretory, we're not going to talk about again the Addison's, and if you use long-term steroid use, can actually shrink the adrenal gland as well and cause major problems. But focusing on Cushing's disease, the clinical presentation, you always have to think about Cushing's disease as increased cortisol. So all those side effects you want to counsel your patients on when they're actually taking chronic steroid use, the same things. You see that central obesity and facial rounding, that moon face. It can have peripheral obesity and fat accumulation. Myopathies, patients are at risk then for bone fractures and osteoporosis. It can increase risk for glucose intolerance and diabetes and hypertension as well. The treatment of choice for Cushing's disease, again, it's an OMA. I want it out of my body. It's surgery. However, we do use pharmacotherapy on occasion for some patients, including those patients who are not surgical candidates. maybe prior to surgery to help with some symptoms, or patients who actually undergo surgery and still have abnormalities with the increased amount of cortisol production. There are two main avenues that are used in the treatment with pharmacotherapy for Cushing's, including blocking the pituitary ACTH secretion. And this is a relatively new medication. It's been on the block for a few years now, but pasireotide is kind of like octreotide, but it's more selective for the type of receptors we're looking at here. It has a significant ADR profile, however, and a lot of endocrinologists kind of shy away from it just because of its ADR profile. It can cause hyperglycemia and type 2 diabetes, can cause significant bradycardia, can increase your risk for gallstones, and cause a whopper of a headache. And the hoops you have to jump through just to get put on the medication, I mean, you have to do an ultrasound to make sure there are no gallstones. You have to do LFTs, have to get A1C, fasting glucose levels, and baseline EKGs on patients prior to being put on it. But it can be effective. Historically, what's more commonly used are agents that help block adrenal cortisol production in the adrenal gland itself. Some of the oral treatments include midostaurin and ketoconazole, the antifungal agent. It has another particular mechanism of action. You could use IV etominate, but that's usually used in significant inpatient when you need rapid reversal and control, and PO is not an option. You measure your success, like most things, with reduction in signs and symptoms. In this case, then also following urine cortisol levels to make sure they're normalized. You can treat some other signs and symptoms. Obviously, the patient has hypertension, try to treat that. If they have glucose abnormalities, try to treat that. And obesity as well, through diet and exercise. RU-486 was actually approved, 2011, 2012, somewhere around down the block, for the treatment of hyperglycemia associated with Cushing's as well. So it's not just for breakfast anymore. Again, for something completely different. Obesity. We've had an obesity epidemic in this country for decades and decades. It's showing signs of finally plateauing out, which is good. The problem is we plateaued fat. It's a problem in this country, obesity with comorbidities, cardiovascular disease, diabetes, and the like. And there have been a lot of new medications, oral medications, in the treatment of obesity just in the last few years. We finally have updated guidelines for the first time in nearly 15 years. Now the ACC, AHA put out guidelines. At the same time, the guidelines for lipids and hypertension came out back in 2013. Unfortunately, they're extremely limited in their pharmacotherapy, and because they kind of stopped taking input into them about 2011 to develop the guidelines themselves, and most of the newer medications came out in 2012 and 2014. The Endocrine Society out of Europe just put some new recommendations out about 14 months ago. Really good review. So if you're interested in the agents and want just one quick good reference, I would highly recommend the Endocrine Society guidelines. They don't suggest one agent over another, but they do a great job in reviewing the dosing strategies and the adverse effects of the agents. The classification for obesity hasn't changed in the last 15 years. It's still the same. Patients are considered overweight based on their BMI of anything greater than 25 but less than 30. And you're considered obese if your BMI is greater than 30. And there's different classifications of obesity as you get larger. So, patient case 5. You're asking me where 3 and 4 went? They're in your workbook. Patients on a maximum daily dose of phentermine topiramate for obesity. Their baseline BMI was 36. Their baseline weight was 255. And the question is, what is the minimal weight loss expected to consider continuation of therapy after 12 weeks? These agents are notorious for a lot of different side effects, and if they're not going to be useful, you don't want to use them any longer. All right, the recommendations for obesity are diet and exercise, diet and exercise, and diet and exercise. It is kind of there's a lot of genetics involved in obesity, no doubt about that. A lot of it has to do with lifestyle, however, sedentary lifestyle, too much food, too much bad food, the wrong types of food. But the cornerstone of therapy is always going to be diet and exercise. Medications are usually reserved for those who are not achieving or sustaining weight reduction with an adequate lifestyle modification, and they're either obese or they have a BMI of at least 27 with another risk factor for cardiovascular disease, such as diabetes or hypertension. Those are strictly out of the guidelines and consistent between the endocrine societies and the ACC guidelines as well. Don't ask me a question on what the best diet is out there to treat obesity. I'm perfectly honest with you, I don't think there is one great one over another. There's multiple ones out there. They all reduce weight if you stick with them. If you don't stick with them, you stop the diet, the weight comes back. Orlistat, been around on the block for a while. It did make it into the guidelines to a certain extent, talking about this agent helps reduce the gastric and pancreatic lipases in the body and helps reduce fat absorption in the intestines. But anytime you start messing with enzymes in the intestines, you're usually going to be in for a whopping ADR profile in the GI arena, including extreme flatulence, oily stool, and loose stools. Not my idea of a good time. And the FDA a few years ago also suggested there may be an increased risk for kidney stones and liver injury as well with the use of orlistat. But still effective. Some of the newer agents in 2012 include leucocerin. How many of you guys remember fen-phen from many years ago? Anybody remember? All right, one of the agents in there was fenfluramine. And it was fairly non-selective and caused a lot of cardiac and pulmonary abnormalities, and it was removed from the market. This agent works in a similar way, but it's much more selective serotonin 2C agonist compared to fenfluramine. But again, lots of side effects. The agents are very effective at reducing weight in patients, but they also have a lot of side effects associated with them. In this case, headache, nausea, dry mouth, dizziness, constipation, memory disturbances, and in some cases, hypoglycemia in patients with diabetes. They are quite good at reducing A1C, however. You know, if you're overweight and have type 2 diabetes, these agents really help reduce A1C in addition to your other medications for the treatment of type 2 diabetes. You want to avoid the use of these agents in patients who are also taking serotonergic agents to avoid serotonin syndrome, like one of our speakers talked about this morning, in particular SSRIs. And in this case, you want to stop after 12 weeks if you don't see a minimum of a 5% weight loss, because if it's not causing at least that amount of weight loss, you probably shouldn't be on it. The risk outweigh the benefits. And what we're going to see, that's a common theme for most of the medications we're going to talk about that are fairly new. Phentermine was the other part of fen-phen, but it now is being marketed with an extended topiramate, which is used for epilepsy, as a weight loss product. It was also approved in 2012, and so it hence didn't make the guidelines. A lot of side effects with these agents. Again, neither agent is necessarily new. It was just the combination product that's actually new. But dyschezia, increased heart rate, memory disturbances, constipation, insomnia, dry mouth, lots of different side effects associated with the agent as well. Again, good for weight loss, good for A1C reduction in patients with diabetes. Women of childbearing age should have a negative pregnancy test before and usually get a pregnancy test monthly after starting the medication, because it can cause some significant problems to the fetus. And like we saw with the previous agent, if you don't see at least a 5% weight loss in 12 weeks, you should not continue to take the medication because, again, the risks outweigh the benefits. Another combo product, again, neither one of these agents is new, but the combination product technically was the combination of naltrexone, bupropion. This was approved in 2014 as an extended release formulation. You usually titrate the dose weekly after about 4 weeks to improve tolerability and limit the adverse effects of the medication. So it's kind of a start low and go slow. You want to reduce the dose in patients with renal impairment. Lots of side effects again. We see the same resounding theme here: nausea, constipation, headache, vomiting, insomnia, dry mouth, increased pulse and blood pressure. It's contraindicated in patients with seizure disorder, just like bupropion is normally. Patients who have uncontrolled high blood pressure, have eating disorders, are taking chronic opioid use because the naltrexone will inhibit that, or if you're already taking a product that contains bupropion or naltrexone in it. And like with the other ones, if you're not seeing at least a 5% weight loss in 12 weeks, stop taking the medication. And lastly, liraglutide. Now, you've known that liraglutide has been approved for the treatment of type 2 diabetes for numerous years. It's now also approved at a much higher dose for the treatment under a different brand name, but the same manufacturer, for the treatment of obesity. And the doses are much, much higher. We're talking 3 milligrams a day is the dose that's recommended for this agent for weight loss. And that's a lot higher than the 1.8 milligrams per day we use in type 2 diabetes. We're going to talk about some of the precautions and contraindications, the use of the GLP-1 agonist and glucagon-like peptide 1 agonist here in a few minutes when we talk about type 2 diabetes. But it has a very similar GI side effect profile, particularly nausea and vomiting. Patients have a lot of nausea and vomiting. It usually will subside over time, but if they take it and they continue to eat, they're going to feel really, really bad. Usually initiate about 0.6 milligrams once daily and titrate up on weekly increments of 0.6 milligrams a week until you get to that 3 milligram. Now, they had to be different. They couldn't come up with a 5% 12-week rule. They had to be different, and they recommend to discontinue unless you see at least a 4% weight loss after 16 weeks. And if the patient can't tolerate the maximum daily dose of 3 milligrams, they recommend discontinuation as well. Again, the new product for obesity is not indicated for type 2 diabetes, and the formulation for type 2 diabetes is not indicated for obesity. It gets confusing after a while. The biggest controversy in the treatment with these newer agents is how long do you treat for? Well, obesity, for the most part, is a chronic condition in many, many patients, just like hypertension or dyslipidemia. If you take these agents away, the weight comes back. It's not a miracle cure by any means. It's not a temporary medication. It's probably going to be considered a chronic medication for life, or unless we develop contraindications to its use or side effects. There are minimal comparative studies. None of the newer agents have been studied against each other. Some of them have been studied compared to orlistat, the first medication we talked about, and appear to be better. But we don't know the long-term safety of these agents. And like we saw with fen-phen, and some things just popped out. It was never approved, but a lot of complications popped out they didn't know about. And we may or may not see that with some of these agents. But again, they're going to be considered chronic medications and have a lot of problems associated with them. Hopefully we'll get new ACC/AHA guidelines on obesity. I don't believe they're coming out in 2016, but hopefully shortly after, that maybe shed some light on if there's a preferred agent or not. But without some new comparative studies, I seriously doubt if they're going to be able to make a recommendation of one over another. So I think the key factor is if you're going to pick a particular medication for obesity is look at the contraindications and precautions and the potential side effects for an individual patient and take your best shot. No pun intended. So the case on patient 5 is the patient needs at least a 5% weight loss in 12 weeks. If the patient's baseline weight was 255, well, a 5% weight loss is about B, about 13 pounds, give or take. So the answer is B. And you make you do math in your head. All right. Now for the last topic, and the one that's juicier. How many of you in the last 2 weeks have seen a patient, regardless of your healthcare system, with type 2 diabetes? Raise your hand. All right. How many in the last 2 weeks have seen a patient with adrenal disorder? Adrenal disorder. Not a lot of hands. That's why we're going to spend the rest of the time on diabetes. There are a lot of different recommendations out there, a lot of different guidelines out there for the treatment of diabetes. Most of my slides, most of my workbook come from recommendations from the American Diabetes Association, unless I talk about another organization. But for the most part, the ADA are the most recognized and the most used guidelines, but certainly not the only ones. All right, the classification hasn't changed since you were in school either. We're going to focus most of our time on the treatment of type 1 diabetes, which is a destruction of your pancreas by antibodies in your body, and insulin is required to live. But most of the patients out there have type 2 diabetes. This too has been an epidemic along with obesity in this country for many decades now, and it appears, hopefully, maybe, we're going to plateau out on this as well in the near future, but there's no guarantees. There are other forms of diabetes, including gestational diabetes, which we get much more aggressive with during the 9-month pregnancy. There's other things such as MODY and other issues such as drug-induced diabetes and genetic defects that cause some other abnormalities. But for the most part, you're going to see patients with type 2 diabetes and to a lesser extent type 1. So, our first case in diabetes management is an African-American female who's 64. She's had over a 25-pound weight increase over the last year. primarily due to her own poor habits of diet and activity. She has a BMI of 44. Both her mother and sister have type 2 diabetes. Glucose level fasting day is 212. So which is the following is the best course of action? Is it to diagnose type 2 diabetes and begin treatment today? Is it to diagnose with type 1 diabetes and begin treatment? Obtain another glucose concentration today, or obtain another glucose concentration another day? Any takers in the high profile here? A lot of yellow out there, mostly yellow, good. The diagnostic criteria hasn't changed in many, many years for either type 1 or type 2 diabetes. The diagnosis is the same from a criteria of glycemic control. Fasting plasma glucose levels should be higher than or equal to 126. They used to be 140 many years ago, but they're down to 126, and that hasn't changed in many years now. Random glucose levels with symptoms, the polyuria, polyphagia, the things that we think about with hyperglycemia, and a random glucose level greater than 200 is considered diagnostic. Oral glucose tolerance test, I don't know if you ladies have had pregnancies, things like that, and had to take one of these syrupy mixtures that cause a lot of, but very, very effective at identifying patients with diabetes. But a 2-hour postprandial glucose level greater than 200 is considered diagnostic as well. A few years ago, they added A1C in there as well. An A1C of greater than equal to 6.5 is considered diagnostic of diabetes. And if you're going to get a glucose level, if it's abnormal, it should be repeated on a subsequent day, not the same day. And hopefully, if you can do the same test, though it's not required. I mean, in other words, you can do a fasting glucose level and an A1C and diagnose a patient. We all know this lady has type 2 diabetes, and we probably should treat now. But officially following the guidelines for this patient, we should obtain another glucose level at another subsequent day to make sure it's still greater than 126. Strong family history here, significant morbid obesity, ethnicity, and the like puts this patient at very, very, very high risk for type 2 diabetes. And so you could make an argument for treating this patient today. But the guidelines would recommend obtaining the glucose level at another day. All right, patient case 7. Patient who's 55 is recently diagnosed with type 2 diabetes. He's been receiving twice daily metformin at 1,000 milligrams, no other chronic conditions, no history of cardiovascular disease. Blood pressure today is 148 over 78, A1C is 6.9, LDL is 112, and the triglycerides are 174. So, if added, which of the agents listed here will have a benefit or potential benefit in reducing both macrovascular and microvascular complications? Again, using our high-tech audience response system. Anybody? Mostly red, some green here and there. All right. I'm not going to spoil the plot. We'll come back to that. Our goals for the treatment of diabetes, whether you have type 1 or type 2, is to prevent the acute and chronic complications of the disorder. Acutely, we're talking about hypoglycemia, DKA, and hyperosmotic non-ketotic syndrome. From a chronic disease state, we're talking about reducing the microvascular and the macrovascular complications. This is where we're spending an inordinate amount of our money and healthcare resources going after the treatment of the complications of diabetes versus trying to prevent diabetes from happening or controlling the disease itself. But those microvascular complications we're talking about, number one cause of blindness in this country, non-traumatic, is diabetes, uncontrolled diabetes. We want to control that. Amputations, neuropathies, the like. Number one cause of end-stage renal disease and obviously uncontrolled diabetes. Highly preventable complications in the average patient if you can get things under better control. Not say that even if you got it under control, those things could never happen to you, but your risk is significantly lowered. From a macrovascular standpoint, MIs and cardiovascular disease are the number one killers in patients with diabetes, like it is in everybody, but at a higher risk in the patients with diabetes. Some consider diabetes a cardiovascular risk equivalent. It's really not. It's really a significant risk factor, but probably not a disease equivalent to cardiovascular disease. The patients are also going to be at higher risk for cerebral vascular disease and peripheral vascular disease as well. So what are our goals? It doesn't depend if you have type 1 or type 2 diabetes. The glycemic goals are still the same. The ADA changed the recommendations for fasting glucose levels from 70 to 130 to 80 to 130 last year in 2015 to be more consistent with the A1C goal. Your A1C in general should be less than 7% per the ADA. Now, there are other recommendations. The American Association of Clinical Endocrinology recommends less than 6.5%. And their mentality is that from an epidemiological standpoint, once you get greater than 6.5, your risk for microvascular complications increases. That's true. We just don't have a lot of great data to suggest that 6.5 is going to be any better than less than 7. But in this day and age of patient-focused care, too, the A1C is a moving target. In general population, yes, it should be less than 7%. But the patient has significant comorbidities, has a fairly short life expectancy, has a lot of other issues going on, has been difficult to control in the past, has no real resources to be more aggressive, whether it's cost of medications or ability to self-monitor their glucose levels. You may consider higher A1C in those patients. There's different recommendations out there for that. How often we need to get an A1C level? Well, at least every 3 months in patients who are uncontrolled, and about every 6 months or twice a year in patients who are at their goal. You can be less stringent in some that we just talked about. You can be more stringent. It's not wrong to go for an A1C of less than 6.5 if you've a patient in their 20s and 30s with the development of type 2 diabetes, because they have a long life expectancy. If you can get them there and minimize side effects of the agents, it's not wrong. It's just, in general, it should be less than 7%. Postprandial. These are hard to obtain in the average patient, particularly with type 2 diabetes, but we do this more so in patients with type 1. But a 1 to 2 hour goal for glucose levels after a meal should be less than 180, and that hasn't changed in many years as well. If you want the goals for gestational diabetes, which are much more aggressive during the gestation period, they're also in the workbook. There are other goals. If you just focus on hyperglycemia in the treatment of diabetes, you're going to miss the boat. We need to treat blood pressure and cholesterol in the age as well, whether it's type 1 or type 2 diabetes. The goal is a moving target for blood pressure, too. Jack and I were just talking a few minutes ago, our second speaker here in nephrology in a minute, on the number of recommendations out there for blood pressure for a patient with diabetes and or kidney disease is phenomenal. Just like a year or so ago, you probably could have found 4 or 5 different recommendations from 4 or 5 different agencies on what the goal blood pressure should be for a patient. The ADA changed in 2015 to try to be more consistent with the JNC8, to be less than 140 over 90. Yet they start being a little more ambiguous about it and say, well, you can consider being more aggressive, i.e. the traditional goals of 130 over 80, in patients who are younger to help reduce the damage to the kidneys. If they already have some damage to the kidneys in the form of increased urine albumin excretion, or for patients with existing cardiovascular risk factors, such as hypertension and the like. But they don't exactly say what age. They don't say, how bad is the blood pressure or anything like that. They just recommend perhaps consider 130 over 80. So if you're confused about it, join the club. Lipids. Up until 2015, they had specific LDL goals, triglyceride goals, and the like for the ADA. They've gotten away from goals for specific cholesterol parameters to be, again, more consistent with the ACC guidelines from 2013. So we no longer have, from the ADA at least, a particular target or goal LDL, which makes my job a lot easier. So if we get the patients under better control, what is the potential benefit from that? These haven't changed over the last few years either, but there is some controversy on glycemic control. Glycemic control can reduce your risk for the development of nephropathy to a certain extent. If you already have nephropathy, it can help attenuate the progression of the disease. It can help reduce your risk for retinopathy perhaps, and neuropathy as well. However, it's very controversial whether it reduces cardiovascular risk. There's been several trials put out over the last few years on does glycemic control improve cardiovascular outcomes, and the general consensus is it may reduce your risk for myocardial infarction, but really not cardiovascular morbidity, mortality beyond that. Cholesterol, however, does reduce your risk for cardiovascular disease, primary prevention and secondary prevention. And we'll talk about that here toward the end of the slides. Blood pressure control, however, reduces both microvascular and macrovascular reduction. complications, excuse me. So the answer to patient case 7, the blood pressure is elevated. It's greater than anybody's goal at 148/78. The A1C is considered relatively under control and the LDL of 112. So the agent here that has the most potential to reduce both macro and microvascular complications would be B, lisinopril. All right, so how do we treat type 1 diabetes? We're going to focus a little bit on this. I wish I had some more slides on this. I had to pull them out because I went from 90-minute talk last year to 75 this year. So I had to pull some slides out of this. Type 1 diabetes is difficult to control, the average patient. And we can't even get into pump therapy today. We can't get into continuous glucose monitoring systems and the like just from a time's sake. But insulin is required to survive. And we've had a lot of new insulins over the last few years. The only new insulin just in the last year was approved in the fall of 2015 is Degludec, the last one in your table here. It's a kind of a long-acting to ultra-long-acting insulin to compete with insulin glargine and insulin detamir. We have now another inhaled insulin that is approved. For you've been around the block, remember Exuberil from Pfizer many years ago? It tanked. We're hoping this inhaled insulin does a better job on the market. It's quite effective, very, very rapid onset. But we're using rapid-acting insulins a lot in patients with type 1 diabetes, particularly pump patients. Gluglycine, aspart, and lispro, because they have a very rapid onset and a very rapid offset compared to regular insulin. NPH is still out there, still fairly cost-effective as well. It's kind of an intermediate-acting, usually twice a day type of insulin. Detamir falls in that category of either intermediate or long-acting, depending on how much you give the patient. In type 1 diabetes, it's pretty effective even at low doses, but most patients with type 2 diabetes with detamir will require BID dosing at lower doses. It's kind of dose dependent. Until you get to higher doses, it's not as effective once daily. But a lot of different options, and certainly a lot more options than we had just 10, 15 years ago. But it gets really confusing of which agent do we pick. A lot of physicians are very uncomfortable with the use of insulins and mismanage patients a lot, both in the inpatient side and the outpatient side. In the treatment of type 1 diabetes, if we're using pumps or we're using injections, we're trying to mimic the natural physiological insulin secretion the body normally does. You have a certain amount of basal insulin secretion all day long and all night long to try to prevent ketosis in the body. When you eat a meal, whether it's breakfast, lunch, or dinner, you have a very big spike in insulin secretion immediately after the meal to combat that postprandial hyperglycemia. This is what we try to do with what we call basal bolus insulin regimens in the body. Basal insulin, again, is there to prevent ketosis and help control fasting sugars. You can use the long-acting insulins if you're not on a pump for type 1 diabetes, so Detamir, Degludec, and Glargine are usually the agents of choice. I put NPH in parentheses here because you can use it. It's just not as physiologic as the other insulins. You use bolus to control those postprandial hyperglycemic episodes, and usually the rapid-acting insulins, glulisine, aspart, and lispro, are used both in insulin pumps as well as by injection. You can use regular insulin, but again, it's not as physiologic. It's not as rapid onset and offset as you normally would get with your own pancreatic insulin output. And you could use inhaled insulin. I haven't seen inhaled insulin studies for basal bolus therapy at this point, but it's not out of the realm. All right, how do we start a patient? If you had to start a patient on insulin with type 1 diabetes, whether by pump or by injection, how would you do that? It's a guesstimate based on their weight. It's usually a weight-based estimate. I've seen endocrinologists like 0.4 units per kg per day, up to 0.6 units per kg per day, as the total daily insulin needs of that patient. Now, everybody's different. You know, some people are bigger, some people are smaller, but this gives you at least a rough estimate to start. And we divide that. Your basal insulin requirements would be about 50% of your total daily insulin needs, and your bolus requirements are the other 50%, and that's usually split up for breakfast, lunch, and dinner. And there's a couple examples in your workbook on how to actually do that. If you're using a pump, you just actually program a basal rate into the pump that sometimes oscillates during the day and during the nighttime. But the pumps are beautiful. You can program them by the half hour to the hour, depending on what type of pump you have. And then again, you give yourself some bolus depending on how much you eat. The idea here in bolus insulin, this gives you a guesstimate to start with, but then you get them to carb count, And so if they're going to eat more carbohydrates, they take more insulin. They eat less carbohydrates, they take less insulin. But that's a lot of education in patients. It takes a significant amount of time, and it takes a lot of ownership on the patient to do that correctly. There may be the need for hyperglycemic excursions to use what we call correctional dosing. This is kind of like think of it as a more patient-specific sliding scale. Sliding scales by themselves are very reactive, they're not very proactive. And so just to put a patient on a sliding scale, particularly in the outpatient setting by itself, is frowned upon. It's frowned upon on the inpatient side as well, if that's all they're doing. The recommendations for inpatient use of insulin highly suggest not using sliding scale insulin solely for the treatment of diabetes in the inpatient setting. But if I have, my total daily insulin needs would be different than yours and different than yours and different than yours. And so if I divide 1,800 by my usual total daily insulin needs, I can come up with a rough estimate of how much 1 unit of a fast-acting insulin is going to reduce in milligrams per deciliter my glucose levels. And so I can build a more patient-specific sliding scale, because there's always going to be issues. You get sick, corticosteroid levels go up, and stress levels go up, your sugars usually go up. But you need something to be able to combat that. Or you ate more than you thought, you didn't calculate the carbohydrate requirements of how much insulin you're going to take. Sugar excursions are going to happen once in a while. But correctional dosing is much better than this blanket one-size-fits-all sliding scale. Insulin management is not rocket science, but like I mentioned before, a lot of physicians are fearful of it. They don't want the risk of hypoglycemia in the agent, in the patient. They don't understand the newer types of insulins and their pharmacokinetics. So the best way I talk to my residents and students about it is to know your postprandial and fasting goals. That's easy to do. We just went over those a minute ago. Then figure out where the problem times are during the day. Because chances are the average patient is not having problems throughout the day. Some of them do, especially the really uncontrolled ones early on. But a lot of times just things happen, whether it's fastings in the morning are up, or maybe it's just my sugars after dinner are up, or maybe it's just after lunch. Sometimes it's meal dependent. A lot of carbohydrate intake happens either at breakfast or at dinner. Maybe we just need to focus on a certain target area of the day to optimize overall glycemic control. When you figure out the problem areas, then figure out which insulin is going to affect that problem area. If it's a fasting problem, you've got to go after your long-acting insulin. That's what's controlling your fasting sugars. So your insulin glargine, detamir, and degludec, those are going to help with your fasting sugars. If it's a postprandial issue, figure out how to adjust then the bolus dose at that time. If it's just after breakfast, fix the breakfast bolus. If it's just after dinner, fix the dinner bolus. Sometimes it's a matter of adjusting medications, but a lot of times it's a matter of just taking care of some behavioral issues. If the patient didn't eat and they still take the same amount of insulin, they go hypoglycemic, don't change the insulin therapy, change the behavior. Make sure they understand, do much more education that, if you skip a meal, you're going to have to skip the bolus insulin. Sometimes it's just as simple as a behavioral change. But a lot of physicians get a knee-jerk reaction. The sugar went down to 50. Oh my God, we got to reduce the bolus rates by 50% in everybody. And then they can't figure out why the A1C and the blood sugars go up. All right. Treatment of type 2 diabetes. Much more fun. Lots of different things going on. I remember going to pharmacy school over 20 years ago, and we had sulfonylureas. They've been around for a while. We had NPH, we had regular insulin, and we had this new kid on the block just approved called glucophage. My, how times have changed. We now have about 12 to 13 different classes of agents now to treat type 2 diabetes, if you include some of the insulin therapies. Lots of different options. And it gets very confusing. And if you ask me, okay, if I take metformin and I fail on metformin, what's the ideal drug? I don't have an answer for you. We'll talk about what you need to take into consideration to maybe help judge that. But there is no one right answer. Some people think there is, but there's not. So some general concepts then in the treatment of type 2 diabetes. Metformin is the drug of choice unless you have significant renal impairment or cannot tolerate the medication. It is the drug of choice initially for the treatment of type 2 diabetes. I don't care if you're looking at the ADA guidelines, the AACE, Canadian guidelines, the Australian guidelines, the European guidelines, they all say metformin. We'll talk about some of the reasons why that is in a moment. The other concept is the average patient on metformin monotherapy is going to fail on that medication if they live long enough. It simply doesn't work long term in the average patient. Type 2 diabetes is usually a progressive disorder, so we're going to need to add things on top of metformin as we go. You wouldn't take away metformin unless the patient was having significant side effects on it or their renal impairment went kaput over the years. So we build upon the metformin. The bigger they are, the harder they fall. In other words, for any individual patient with an A1C of 11 versus 8, on the same dose of an agent, I'm going to get a bigger overall absolute reduction in my A1C with the same dose of the same medication than I'm going to get for somebody who has an A1C of, say, 7.5 or 8. And so it's kind of the law of diminishing returns in some cases. We need to be more patient-focused based on the recommendations. All the recommendations out there suggest that these days. To bring the patient in on our care decisions. What are their preferences? You have to ask about these things because there's a lot of issues, a lot of side effects, a lot of misnomers, misconcepts out there on the internet. Sometimes I think the internet is the most scary thing with respect to patient education when it comes to their medications. And these TV commercials you see with the modern day ambulance chasers, they scare the bejeebers out of patients. Well, that's what they come in. That thing causes cancer. I'm not going to take that medication. Then I spend the next half hour why this medication does not cause cancer, and that guy's an idiot. He just wants your money. He doesn't want your money. He wants the manufacturer's money. We digress. All right. So what do we add on top of metformin? What do we need to take in consideration to treat type 2 diabetes? Well, how high is the A1C? Some agents are really good at lowering A1C. Some of them are not as good at lowering A1C. So my decision if my A1C was 7.5 may differ greatly than if my A1C was 9 or 9.5. Do I have a fasting or postprandial problem or both? Some of the agents are very focused on postprandial sugars, and sometimes that's all the patient has. Metformin's working on controlling the fastings, and they just, every time they open their mouth, the sugars go up, but the fastings are just fine the next day. Obviously, with anything is what precautions or contraindications may exist. What's the risk for hypoglycemia? Is the patient having frequent bouts of hypoglycemia? Because that's going to gear me towards some medications which a lower risk of hypoglycemia compared to others with a higher risk. Is weight an issue? Is the person wanting something that's weight neutral? They want to lose weight, or if they don't care if their weight goes up? And cost. We have a lot of newer medications out there, and they are very expensive medications. They're causing a lot of hardship on patients who don't have very good insurance. And do they have a preference? Ask them, do you care if we take an injectable medication or an oral medication? And I'm a complete wimp. I'd be a terrible diabetic. I can't even poke myself to self-monitor my blood glucose if I wanted to. I could have you do it. I could have anybody in here come up and poke me right away. I had no problem with that. But I could not poke myself. Something about self-injurious behavior, something I just can't figure out. I'm sure if I developed type 1 diabetes, I was going to die if I didn't actually do insulin. I'd probably figure it out right away. But up until that time, I'm not trying. All right, so in addition to metformin then, we have preferred agents over the last couple of years based on the 2015 updates in the treatment to hyperglycemia for type 2 diabetes from the ADA and the European Society for the Study of Diabetes. Preferred agents are containing sulfonylureas, TZDs, basal insulin, the DPP-4 inhibitors, dipeptidyl peptidase 4 inhibitors, the glucose-like peptide 1, GLP-1 agonists, and the sodium glucose cotransporter 2. You're not anything in diabetes if you don't know acronyms. But these are the preferred classes of agents to add on. Less favored options including the glucosidase inhibitors, bromocriptine, and cholestyramine Welchol. Simply because they have very minimal efficacy in some patients and or significant side effects or both. It doesn't mean you can't use them, it's just they're less preferred. So we're going to go through these different classes here fairly rapid succession to give you an idea what are the benefits, why would you maybe choose one agent, and what are the risks, and maybe why not choose another agent. So first, patient case 9. A 55-year-old male with, I guess not a non-gender here, type 2 diabetes for 6 months on the usual daily dose of metformin. Fasting sugars are great, but the postprandial sugars are now increasing up in the low 200s. He's very worried about weight gain and doesn't want anything that's going to increase it. What is the most appropriate option for this patient? Anybody? A little bit of red, a little bit of green, good. Patient case 10. We're We're going to come back to the answers here. 4 years history of type 2 diabetes, male who's 66 years of age, A1C is only 7.7, not bad. He's altered his diet and then exercising regularly now, maxed out on his metformin. What is the best option for this patient? Is it A, continue his current medication and improve his diet and exercise? Is it to discontinue metformin and initiate exenatide? Is it to add bromocriptine, or is it to add sitagliptin? We'll come back to that. A little bit of yellow, good. All right, why is metformin considered the drug of choice? Great A1C reduction. It's now generic and obviously quite cheap on the $4 plans out there. Very well tolerated if you don't start out too high doses and let the patient get used to the GI symptoms. Associated with some weight loss, not a lot, but some. Has some lipid benefits and possible cardiovascular benefits, particularly in obese patients. It does cause a lot of GI side effects, so we start low and go up a little bit slower. You don't start somebody on 2,000 milligrams a day, they're going to come back very angry at you. Cramping, diarrhea, nausea, and vomiting. We always heard about lactic acidosis as a possible side effect. Very, very rare. In some camps don't even think it exists at all. And a very low risk of hypoglycemia. Those contraindications, however, are still out there. You learn in pharmacy school, 1.4 for serum creatinine for women, 1.5 for men. There's the other camps now, including now the ADA is suggesting that you could do alternatives. Using the GFR is a better idea of a cutoff than the actual just creatinine in the average patient, because somebody's creatinine doesn't necessarily include a lot of issues that may be better assessed based on the overall kidney function using the GFR. And you certainly probably wouldn't initiate metformin in somebody whose GFR is less than 45. If it does reduce to less than 45 and they're already on it, you may want to consider 1,000 milligrams a day as your daily dose. And if it goes less than 30, to stop the medication altogether. Inpatient-wise, again, hold metformin for patients going under iodinated contrast media because it can be nephrotoxic, and to wait 48 hours and make sure you get a serum creatinine before restarting it to make sure it didn't trash the kidneys. And hold for anything greater than a minor surgery. All right, quickly through the agents. Benefits of sulfonylurea has been around for decades. Great agents, great reduction in A1C. The average patient, at least early on, affects both postprandial and fasting sugars. It's dirt cheap. However, associated with significant weight gain and a significant risk for hypoglycemia in the average patient. So a lot of endocrinologists are trying to kind of shy away from the use of sulfonylureas. Those of you guys who worked at the VA, that's not going to happen any day soon. Meglitidines work very similarly to the sulfonylureas, very similar mechanism of action, slightly more rapid onset and more rapid offset. So the risk for hypoglycemia, while still there, is a little bit less, and they're very focused on postprandial hyperglycemia as well. I like them for patients who have significant postprandial issues. It's kind of like my bolus insulin in a pill. But you got to dose them at mealtime. There still is a risk for hypoglycemia. They can cause weight gain just like the sulfonylureas, and they cost a lot. The TZDs, great. There is not a better medication out there to treat type 2 diabetes and insulin resistance. Great medications. Great reductions in A1Cs, preserving beta cell function, possible cardiovascular benefits in some patients with a history of cardiovascular disease. But they've gotten a big bad rap with respect to their side effects over the last few years. Weight gain is associated with them, peripheral edema. You want to avoid them in patients who have symptomatic class 3 or class 4 heart failure. There's a question if they actually have a risk for bladder cancer. I can show you a dozen articles out there that suggest they don't. Another one just came out this week from the British Medical Journal, says they do. If it is, it's very, very small risk. The FDA has not pulled the agent from the market, because right now you can really only get pioglitazone. It's very controversial whether they even cause heart failure. They probably do not cause MI, but they may cause an increased risk for proximal fracture risk. And the risk is higher in women than men, but it's still in both genders. The newer kids on the block, the DPP-4 inhibitors, great focus on postprandial sugars, once daily administration, easy to take, very well tolerated. The problem with this is they don't work as well as some of the other oral agents we talked about. Their A1C reduction is more modest than that. There's no dose titration. You start them out the maximum daily dose unless they have renal impairment. Sitagliptin, 100 milligrams. That's it. If they don't respond, then, well, you got a pretty costly medication on board. Because they are expensive. They're fairly new. There's a big question right now if there's a heart failure risk. The FDA just put out a statement this week that they are going to increase the awareness of a possible heart failure risk with saxagliptin and allogliptin, which I'm not really sure why, because allogliptin didn't show a statistically significant increase for heart failure in its safety studies, but saxagliptin did. But sitagliptin didn't, so it gets really confusing. We don't think it's a class effect, but it may be just more of an agent effect. And it's very controversial whether they cause pancreatitis. In my personal opinion, they do not cause pancreatitis any more than anything else to treat diabetes. But I probably wouldn't use them in a patient with a history of pancreatitis, because if you did and they have another bout of pancreatitis, which they probably will, you might be on the bench. All right, sodium glucose transport inhibitors, the newest kids on the block. Great once-a-day medications, really good A1C reduction, pretty well tolerated, has a certain effect on weight as well, not big weight reductions, but going in the right direction. Problem is they're relatively costly. We don't know the long-term effects of these agents because they are that new. They can cause UTIs and genital mycotic infections, fungal infections. There are some case reports out there of severe pyelonephritis arising as well. They can cause a diuresis, particularly in older patients. You want to make sure they're euvolemic before starting. And they may cause what we call euglycemic DKA, and particularly in patients with type 1 diabetes, because they've been getting used in patients with type 1, because they're a very insulin-independent mechanism of action. The GLP-1 agonist, like we talked about, liraglutide fits in that category that we talked about for obesity. These give a good reduction in A1C. They have a pretty significant weight loss associated with them, even when we don't use the really, really high doses used for obesity. Variety of different dosing strategies, either from BID to once daily to once weekly. We have 3 different once weekly formulations now. The risk for hypoglycemia by themselves is pretty small, but if you add insulin or sulfonylurea onto that, it increases significantly. Weight loss is a good side effect, but a lot of nausea and vomiting, which usually improves over time in the average patient, but can still be a problem for some patients. But if they can tolerate it the first week or two to a first month, the chances are that going away is pretty significant. But they are injectable, and they have a certain amount of aspect of that for patients who don't like injections like myself. And there may or may not be a risk for pancreatitis like the DPP-4 inhibitors. We don't think they cause it, but again, if a patient has a history of pancreatitis from a liability standpoint, you might want to shy away from the medication. Precautions, again, the history of pancreatitis, they slow gastric emptying, so we are shying away from them in patients with significant gastroparesis. Moderate renal impairment for patients on exenatide. Contraindicated for exenatide regardless of formulation, once weekly or BID if the GFR is less than 30. And patients with a history of, or family history of medullary thyroid cancer. This is a risk that they found in rodent models years ago when they were first started getting approved. There have been no case reports in humans that I know of. We don't think it increases the risk for humans, but it is a boxed warning. So patient case 9, this guy has good fastings, bad postprandials, but doesn't want his weight to go up. So the only thing on this that does not increase weight would be B, liraglutide. All the other 3 listed there, particularly insulins and sulfonylureas and the like, have a significant increased risk for weight gain. But pioglitazone does as well. For this patient who has an A1C of only 7.7 on maximum daily dose of metformin, already doing well in his diet and exercise, he doesn't necessarily need to improve that anymore. Nice if he could, but it's probably less likely of an option, may not be the best choice. We don't stop metformin and start something else unless the patient's having a problem with the metformin, so B is out. Bromocriptine doesn't do a darn thing anyway, so I wouldn't use it. So D, adding sitagliptin, particularly because it's a postprandial issue. It's weight neutral. And again, 7.7 is not that high of an A1C. All right. Right on time. Everything you want to know about treatment of type 2 diabetes. Diabetes complications. Don't get them in the first place. That's the moral of the story. But you're going to see, inpatient folks, of course, DKA is a significant problem, particularly in type 1, but it can happen in patients with type 2 diabetes as well. It's marked by significantly elevated blood glucose levels, of course, the ketoacidosis, and also associated usually with significant dehydration. Some of the common signs and symptoms associated with DKA include that fruity acetone breath you think about, tachycardia, Electrolyte abnormalities, of course, ketones in the urine and in the serum as well. Patients often complain of thirst because of the dehydration. In worst case scenarios, you can have mental status changes. I've had a lot of patients with type 1 who complain they always get stomach pain prior to when one of these episodes is about to occur. And so that's always a big flag warning in my patients. Usually it's going to be some kind of threat to the body. If they've already known they have a diagnosis of type 1 diabetes, infection or acute illness, or simply not using their insulin or using it inappropriately are the biggest causes of diabetic ketoacidosis. How do we treat it? Well, if you know the underlying issue, fix it. If you know it's an infection, fix the infection. It's not about normalizing the blood glucose levels in the body. We're not shooting for this 80 to 130 in the patient with DKA in the inpatient setting. Fluid replacement, the IV sodium, if anybody wants good recommendations, the ADA statement on this from a few years back is really, really good, spells all this out very nicely. And it's in your references in your workbook. A start insulin drip, usually 0.1 units per kg as a bolus, and then a drip 0.1 units per kg. If you don't get a decent reduction in the sugars after an hour or two, they double the drip rate. You're going to want to hold. Remember, insulin can drive potassium into the cells. And you'll remember from critical care and fluid electrolytes and the like. So you want to hold if the baseline potassium is less than 3.3 until the potassium is actually corrected. And again, whether you're going to do supplement potassium depends on the baseline potassium level, of course. The goals are, again, not 80 to 130, but getting glucose less than 200 should shut off ketosis adequately enough. So that's what our goal is, not to get too crazy with it, but at least get the sugars less than 200. And get at least 2 of the following 3 goals as well, including getting a pH greater than 7.3, get the bicarb level up to at least 15, and get the anion gap less than 12. Once you got at least 2 out of 3 of those and your glucose levels are 200 or less, then you can talk about converting the patient from IV to subcutaneous insulin administration. All right, diabetic nephropathy, or more politically correct now, we're supposed to say diabetic kidney disease. It's still diabetic nephropathy. Normally, you're going to get a random urine albumin to creatinine level in the average patient with type 2 diabetes after 5 years from diagnosis, in type 1 diabetes after 5 years, and at diagnosis with type 2 diabetes. We got away from the terms microalbuminuria and macroalbuminuria and full-blown proteinuria, and now we're just saying increased urinary albumin excretion. And anything greater than 30 milligrams per gram is considered abnormal. But obviously, you guys remember, ACE inhibitors and ARBs are the drugs of choice to help treat this. But now it's diabetic kidney disease. That's 2006 update terminology from the ADA. Neuropathic pain. How many of you guys have heard a patient talking about some tingling or numbness and immediately the physician just threw gabapentin at them? Anybody? It happens all the time. It's never been studied for tingling and numbness. It's been studied for neuropathic pain, which is a terrible thing to live with if you're a patient with diabetes and have neuropathies. There are a lot of different classes of agents we can use. They all are wrought with a lot of side effects. Some of them may be better tolerated than others. There may not be anything that's more effective than any other class. But the tricyclic antidepressants, the TCAs, have been used for many, many years. Very effective, but a lot of side effects, particularly the anticholinergic side effects. Many of the anticonvulsants, particularly gabapentin and pregabalin, are used very frequently. Pregabalin is approved for the particular indication through the FDA. And they may be tolerated. They may not be better than TCAs, but they are more tolerated than the TCAs. But even then, they're wrought with lots of side effects. Duloxetine is also approved. It is a combination SSRI, SSNRI, often used for the depression. So if you have both neuropathies and depression, you got yourselves a winner. It's kind of like if you have high blood pressure and BPH and using an alpha blocker, alpha agonist. Antagonist, excuse me. Tramadol, APAP, has been studied as well, and there's actually an approved opioid just for neuropathic pain out there as well, but it's not very commonly used. But whatever works. There's contraindications to some of these. You got to watch renal function, particularly with gabapentin, pregabalin. Whatever works for the patient is the most appropriate thing. But you have to assess for efficacy. I can't tell you how many times a physician will start a really wimpy dose of gabapentin, doesn't do a thing for the patient, and nobody reassesses it, and they're having a lot of somnolence, a lot of side effects, and nobody's addressing whether it's actually working or not. And the doses you need are not like the 300 milligrams once a day. You usually need significant doses of gabapentin and pregabalin to really affect the pain levels. And even then, it doesn't eliminate the pain. And most studies, if the pain scale of 1 to 10, they may start out a baseline of 7, and they go down to a 4. Well, 4 is definitely better than a 7, especially if you live in chronic pain. There's no doubt about that. But 4 is not 0 or 1. Blood pressure control. Again, moving target as far as the goal is concerned, but again, most regimens should have a baseline use of ACE inhibitors or ARBs. I favor ACE inhibitors myself because there's simply more data out there with ACE inhibitors in cardiovascular disease than ARBs. And there was a new recommendation put out there 2 or 3 years ago from the ADA to consider taking one of the blood pressure medications at night. There was one small study out there, a chronotherapy study, that was quite interesting, where patients who took blood pressure medication at night had better overall blood pressure control throughout the day, had less variability in their blood pressure, and actually had less cardiovascular events. And so what a low-hanging fruit and easy thing to talk to our patients about, because it doesn't cost anything as long as the patient can remember to take them at night. I can't remember to take anything at night. I fall asleep in front of the TV or what have you. I'm on atorvastatin now. I used to be on pravastatin. I had to take it at night, and I swear I was about 50% compliant with the medication. I can't remember to take anything at night, but I got put on atorvastatin. I take it in the morning. Everything's fine. Lipid management. Like we mentioned a few minutes ago when we first started talking about the goals, the ADA is trying to get a little bit more in line with the recommendations from the ACC-AHA as well. But they're a little bit different. They're a little more subtle. Yes, we've gotten away from LDL goals, which is a good thing. I think that's been needed for quite some time, in my personal opinion. But they look at whether you have cardiovascular risk factors, whether you have overt existing cardiovascular disease, and what your age is. So they limit the ACC-AHA guidelines, as you'll learn about a little bit more, I believe, on Sunday, is they don't necessarily look at other risk factors on the recommendations as much as the ADA does. But if you have diabetes and you have either hypertension, you're a smoker, you're overweight or obese, or you have an LDL baseline greater than 100, that's considered a cardiovascular risk factor, which will increase your overall dose of statin. If you have overt cardiovascular disease as well, again, the different age groups are less than 40, 40 to 75, and greater than 75. From a lipid management standpoint, if you have overt cardiovascular disease, it's the same as the ACC-AHA guidelines. You should be on a high-dose statin. And the equivalent is about 80 milligrams of Lipitor or 40 of rosuvastatin. And 80 milligrams of Lipitor is really the best studied high-dose statin that we have out there. They also recommend 40 or 80, but really I don't think 40 has ever been studied in secondary prevention, at least not that I've seen. Now, if you're talking about primary prevention and you have these other risk factors, if you're less than 40 or greater than 75, they recommend either moderate or high-dose statin therapy, simply because we don't have a lot of data in patients who are less than 40. We have very, very little data in patients who are greater than 75. If you're the age of 40 to 75, they recommend high-dose statin therapy if you just have one other risk factor in addition to your diabetes. And I will buy anybody a glass of wine at the bar downstairs later this evening if they can find me a primary prevention study in type 2 diabetes that used high-dose and high-intensity statin therapy of 80 milligrams of atorvastatin or 40 of rosuvastatin. To the best of my knowledge, it does not exist. But they're betting their hedging their bets, excuse me, that you have other risk factors in addition to diabetes, your risk is sufficient enough to warrant high-dose statin therapy, even though we don't have a lot of data to prove it. If you do not have any risk factors for cardiovascular disease and you're less than 40, you're good, nothing to do. Even if your LDL is 130 or 140 or 160, you're all right. If you're greater than 40 years of age, moderate dose statin therapy is recommended. And again, the dosing now from the ADA is similar to the ACC, so moderate dose statin therapy, high dose statin therapy. You guys will talk about that on Sunday. 51 seconds to talk about antiplatelet therapy. 43 seconds. All right, secondary prevention, everybody, unless they have a contraindication, just like anybody else with cardiovascular disease, should be on a dose of aspirin a day. From a primary prevention standpoint, there's conflicting information out there of does primary prevention in type 2 diabetes do you any good with aspirin therapy? And I can't find a single trial out there that says it definitively is looked at prospectively says yes, but we're hedging our bets here again that if you have at least a 10% risk for cardiovascular disease in the next 10 years, you're probably high enough risk to potentially benefit from an aspirin, even though we don't have great clinical trial data to show for that. The ADA changed the recommendations this year, so both sexes, both men and women who are greater than the age of 50, with at least one other risk factor, probably fits in that category of a 10-year risk that's higher than 10%. So if you have type 2 diabetes, you're over 50, and you have hypertension or obesity or smoke, probably have the equivalent of 10% or higher, and you should be on an aspirin a day. And Plavix should be used as an alternative if a patient cannot tolerate aspirin, and we are at time.